I'm Dr. Michaeli. I'm a peripheral nerve surgeon, and we're going to talk about abdominal cutaneous nerve entrapment syndrome, or ACNES. This is a pathology that's often underdiagnosed, understood. Usually what this is going to be is a patient with severe abdominal pain. And when I say severe, it's not necessarily that they're going to the emergency room, although oftentimes they do eventually go, just because it's so unrelenting. It's more going to be that annoying pain that just doesn't go away, as opposed to the one that doesn't let you stand up or get out of bed at night. The important thing to note is that this is abdominal wall pain, not abdominal pain. So it's not coming from inside the belly, it's coming from outside the belly. The diagnostic criteria on physical exam, there's something called a Carnett sign, which is where when you tense the belly, so think about either doing a sit-up or bearing down like you have to poop really bad, and one area will really hurt. Sometimes it can cause muscle spasticity as well, so you could also feel one tight part of the muscle. The intercostal nerves, they course from under your ribs, they come all the way around, and then they pierce your rectus. So they come and make a sharp turn from inside. And as they pierce through the fascia, they can often become entrapped. And why does this happen? Sometimes there's no explaining why it happens. Sometimes it just does happen. Other times it can be caused by aggravating factors. For example, I've seen it happen from aggressive liposuction and inadequate postoperative recovery protocols, where the fibrosis ended up really scarring down onto these nerves, causing a chronic pain. Other times I've seen it from port sites. So again, these are the same nerves, different locations on the nerve, but they're all following the same issue. I don't really differentiate if someone has a nerve that's cut, such as a neuroma, from just an entrapment, because the treatment is going to be more or less the same either way. If you look at this picture over here, I used AI to make it a little bit less gruesome. This is actually an intraoperative picture that I took myself. You can see that the vessel loops are around the main nerve and where it divides into the sensory and the motor component. And these nerves are about 1/3 of a millimeter. And these nerves were confirmed to be the correct nerves using an intraoperative nerve stimulator. What I did for these nerves is I did a targeted muscle reinnervation, where I resected those nerves, and then I connected the sensory portion to the motor portion in order to treat it. Sometimes I do an RPNI for these. It really depends where the pathology exists. Before I offer someone surgery, I usually want to make sure that we can have a high likelihood of success, because oftentimes these surgeries can be fairly large for the exposure. So what I do is I send the patients to a skilled ultrasonographer, and I ask them to put a very small injection between 0.5 and 2 milliliters of simple lidocaine around the nerves, and usually I'll only do 2 to 3 segments tops at a time. So figure it could be intercostal 9 and 10 to see if the pain goes away. Then the next day it might be 10 and 11. See if the pain goes away. It can change based on high likelihoods, but essentially you don't want to numb everything. You don't want to do a field block. You want to only numb specific nerves so that we can look for those nerves and fix it. So for example, I know that T9 is going to be just lateral and a little bit higher than the belly button. T10 is going to be about the level of the belly button, T11 a little bit below. So we usually try to confirm that by doing a fairly proximal injection. I tell the patients to walk around, do all the activity you want to do, go horseback riding, play basketball, whatever you enjoy. See if the pain's gone. And if so, there's a high likelihood of success for surgery. What to expect after surgery? Well, depending on how high we have to go, a lot of times you have to raise fairly large flaps. So sometimes you might have drains placed. This can often be a lot larger of a surgery than some of the others. Sometimes you might have to wear a compression garment. A lot of patients, depending on the severity of their symptoms, they will report differences in the pain. So you will have the incisional pain, the pain from raising the flaps, but it will often be different from the initial pain. And again, usually that's a fairly positive finding. As I mentioned before, I run a narcotic-free practice, so it's Tylenol and Advil, and sometimes I'll use some novel non-narcotic pain medications. So far, my patients have been very happy with that. I find that the results improve a lot faster. So that's abdominal cutaneous nerve entrapment.